Okay, folks, we're just going to walk through a bit of, we'll just bring the legs over, foreign body airway obstruction and the management of it. A very, very challenging call and situation to find yourself in, particular with kids. So just going to walk you through what we're going to have you do here. The reason why you get various opinions about what to do in foreign body airway management, in both in children and adults, is because we don't know the right answer. We don't have the population to do a randomized control trial to really know. So it's expert opinion. What I've pulled from is from Ron Wall's book and from Up to Date. But you'll notice that protocols across the country are going to vary. So you're going to have to follow your local protocols. You're going to find the same things from heart and stroke are going to bleed into all. Everybody's going to be doing chest compressions. Just whether or not you choose to do things, and everyone's going to do direct laryngoscopy with McGill forceps, but whether or not you're going to shove a obstruction right main stem or not, some people are in favor of that and some are not. Up to Date in their algorithm recommends that, as well as Ron Walls in his book. George Kovac and Adam Law in the AIM course doesn't have a chapter on foreign body airway obstruction. So we're going to just chat through how this is going to go. So when you arrive on scene, you find somebody in foreign body airway obstruction. Usually there's a history. In children, we have a history of somebody that has a sudden onset of altered level of consciousness, not always witnessed. Often, if it is witnessed, there's going to be coughing, choking, raspy voice, and then becoming unconscious depending on the degree of obstruction. We're going to be talking about complete obstruction or life-threatening choking here. Obviously, they're going to become cyanotic, and they might be clutching their throats. In smaller children, there might be a quiet or silent cry in infants. So when we approach for conscious folks or children, you'll be doing Heimlich as per ACLS. There we'll do Heimlich until the patient becomes unresponsive. Typically in EMS, as we respond as paramedics, these folks have either cleared their airway or their airway isn't completely occluded, so they're awake or they're unconscious. So most of the choking that I've arrived to have been unresponsive patients or completely fine people that have coughed up whatever was blocking their airway. So we're going to focus on the unconscious individual. So when you find a patient, we approach CAB for all of these folks that are blue. We walk up, we find a patient that's unresponsive, confirm that they're unresponsive. Hello, no response to verbal. Response to painful stimuli, no response to painful stimuli, we say unresponsive. We go to pulse, brachial or carotid pulse. We will find a pulse depending on how long they have been experiencing asphyxia. So we'll say that for our case here, we find a pulse. Then we're going to turn our attention to airway. We're going to look in the airway. Often you're going to find vomit here. So we'll clear the airway with suctioning, so we'll suction out the airway. So whatever you can see, we'll suction out, suction the airway out, and then we're going to assess breathing, if we have adequate chest rise and fall or not. If we don't have adequate chest rise and fall, we're going to ask for a bag valve mask and an OPA. I'd like to thank Nick for showing up today. Making this all happen. So we're going to try bag valve mask, and the OPAs are in the end of this bag. Okay. So we put an OPA in. We'll put the bag valve mask on. We'll try to get chest rise and fall, not get chest rise and fall. Our immediate response will be go to try two-person chest rise and fall. No chest rise and fall. With two-person bag valve mask and an OPA, we could say fairly confidently, given our patient population and a body size like this, that we have a foreign body airway obstruction, that we're getting no chest rise and fall, visible chest rise and fall. We're going to stop chest rise and fall and start chest compressions. So Nick will same as CPR, we're going to do continuous chest compressions we'll come by. He's going to count to 30 to remind me to go have a look in the airway. But most experts would recommend not to return to positive pressure ventilation unless you have something come out of the airway once you've confirmed that you do have a choking patient. For risks that you might be, whatever Nick's doing to do pressure, to create thoracic pressure, to squeeze on those lungs, to push whatever is in the airway up and out. And some experts would advocate, and we follow along with it, we don't want to blow it back down if we don't see anything. So until you see something productive in the airway, we'll keep doing chest compression. So I'll just get you to pause on that for a second. So with your compressions, just normal CPR, third the chest diameter, 100, at least a compression rate of 100 compressions per minute up to 120, allowing full recoil, and we're really trying to create lots of pressure in that chest. Meanwhile, is an ALS provider, or depending on the province you work, a BLS provider, somebody's going to be going to get the laryngoscope and will to be able to utilize McGill forceps. So if that's within your scope of practice, in the jurisdiction you're working, or if you're an advanced care paramedic in Canada, you're going to be grabbing your laryngoscope and hauling out your equipment to prepare and set up for this. So Nick will be continually doing chest compressions, and you'll be setting equipment up. Now, references like up to date say about a minute of chest compressions before you go to McGill forceps. In reality, you're not going to have to plan that. It'll be as soon as you get them out, you'll have burnt a minute at that point, typically, but you can keep that in mind. So you'll grab an appropriate size blade and tube, and pediatric McGill forceps is what you'll want. So I'm going to grab, we've already measured this guy out, that he's a 5.5, and he does need a pediatric stylet. A 5.5, but you just use your Broswell tape to measure that. If you don't have a tube out, just grab your and you and you have your McGill forceps available and your laryngoscope. Just grab those and go look and see what you can see. But you may need a tube here in a moment. So we'll have our tube in our sterile packaging. So ideally, you would have both ready if they're readily accessible. When he's doing chest compressions, you may have him continue doing chest compressions, or have him stop doing chest compressions while you're doing direct laryngoscopy. This is different than in a pulse. We know, it's not like intubating during cardiac arrest, where we would not want to at any point interrupt CPR. We're focused on getting this airway going. And while we're going, it's good to reevaluate as we go every 30 seconds. You can delegate to your partner to also confirm that we still have a pulse, which is a very useful thing to know. But our focus absolutely is getting to the root cause of why our patient's unconscious. We're going to approach direct laryngoscopy. This video isn't about doing direct laryngoscopy or in particular, but McGill forceps, we're going to come down the right-hand side of the obstruction. We're going to come and try to pick whatever we can, if it's at the glottic opening or between the vocal cords, we'll pull that out. Depends on what it is. Sometimes it will pull out in one piece. Sometimes you get multiple pieces depending on what's obstructing the airway. And various things can be very difficult. So you'll go in, make an attempt, do some picking, and then if you don't make any grounds, then go and initiate chest compressions again. And you'll just cycle back and forth between that. Typically, in adults, the obstruction is at the vocal cords. In some children, it's at the vocal cords. And in other children, the obstruction, depending on the size, might be below the vocal cords. And that does make a difference, according to what Ron Wall's book has said and what Up to Date is telling me as of today. Is that you make a decision of which way to route. So if the obstruction is above the vocal cords, that means that a surgical airway, like a needle cricothyroidotomy or percutaneous cricothyroidotomy, would be useful, because you're not going to run into the obstruction because the obstruction is above where the surgical site is. Whereas if your obstruction is below your surgical site, the surgical airway is not going to do you anything. So if you can see the obstruction at the vocal cords, then that would be an indication, if we can't get it out after multiple cycles of chest compressions and attempts with McGill forceps, to set up to do surgical airway, depending on the age of the child, whether that's needle cricothyroidotomy or an open cricothyroidotomy with bougie or whatever kit that you're using. For this child, it would be a needle cricothyroidotomy in our practice here or locally for us as we would manage this child. So to kind of rewind and take you all the way through that, if we arrived unresponsive patient, we find the patient unresponsive, we confirm a decreased level of consciousness. Because we have unresponsive patient that's cyanotic, we're going to check and make sure that we have a pulse. We see that we have no pulse, we're going to assess airway and breathing, look in the airway. Often in these choking patients, there will be vomit around the airway, so we'll get the vomit out either by rolling the patient over and probably suctioning as well. Once we've suctioned the airway, we'll see if we're breathing or not. We'll note that we're not breathing. We'll ask for a bag valve mask and an OPA. We'll put our OPA, size our OPA, put our OPA in, put our bag valve mask, get chest, see whether or not we get chest rise and fall. If we don't get chest rise and fall with one person, good technique, we'll put our bag valve mask on, try two person, see that we still don't get good chest rise and fall in a situation, a story that leads us to believe foreign body airway obstruction. We say absolutely we have a foreign body airway obstruction because we're not getting chest rise and fall. Delegate chest compressions, 30 compressions, 30 cycles of 30, but we will not be ventilating once we've confirmed that there's a foreign body in the airway. Get your McGill forceps and your laryngoscope out as soon as possible. Go in and pick at what you can, and then we'll be cycling every 30 compressions, going back to see if we dislodge that obstruction a little further so you can go in again. And if that's unsuccessful, then we have to decide where is the obstruction. If the obstruction's above the vocal cords, then we could attempt a surgical airway and prepare for that. And if the obstruction is below the level of vocal cords, in pediatrics, some, and what I'm going by with UpToDate and Ron Walls would recommend that you take an appropriate size endotracheal tube with a stylet and intubate that patient and try to send that tube and push that obstruction down into most likely the right main stem bronchi. So shove that back down, pull back out, see that your tube don't have a piece of something lodged in the end of your tube. Intubate again to the appropriate depth, put your stylet out and try to ventilate through that. That is more, you'll find protocols in Canada where the medical controller or medical advisor has said, yes, I want you to do that, and you'll find others that are adamantly against that. So there's a little bit more discretion. In our area, and based on the references that I'm using, that's how they'd like to approach. So a little bit of a division at the end if the obstruction's above the vocal cords or below the vocal cords. Make sense? Okay.